All right. So, hello everyone, and thank you for joining us this evening for the fourth week of the Rice Institute and Rugby Research and Injury Prevention Group 2026 Journal Club. We will begin our first Journal Club presentation, and our first intern is Kevin Serrano.
Thank you for that introduction, Julia. Hi, my name is Kevin Serrano. I'm a rising sophomore from Brandeis University. I currently reside in New York City. And today we will be looking over the neurodegenerative disease risk among former International Union rugby players. This was a paper published by Russell E.R., McKay D.F., Lyle D., and fellow collaborators. This was published in the Journal of Neurology and Neurosurgery and Psychiatry in 2022. So looking more at traumatic brain injuries and neurodegenerative diseases. Traumatic brain injuries lead to neurodegenerative diseases, the most common of which is CTE. This is actually suspected to be responsible for 3% of the general population's dementia. And the most common type of traumatic brain injury that happens is actually concussion. Now, looking more specifically at concussions in rugby, we can see that concussions are actually the most common type of head injury in rugby. It really accounts for 20 to 26 of nearly all recorded injuries. I'm not sure if anyone this weekend who went to tournaments might have experienced somebody who had a concussion, but it's actually quite familiar to be able to see one. Looking more into this, we can see that there's actually 2.08 concussions per 1,000 player hours in casual play and nearly 20 concussions per 1,000 player hours in professional play. But something to keep in mind is that in the sense of this article and this research, rugby was not technically considered a professional sport until 1995. So these numbers could be much higher as a result of different rules and safety risks being implemented in order to be able to stop concussions in modern times. Now, looking more specifically at the purpose of the article, we can see that the purpose of the article was to identify the frequency of risks that professional rugby athletes have in developing these neurological diseases. We can analyze the difference in frequency of these NDDs between professional athletes and the general population, and really just looking at quantifying the disproportion between the general population and the frequency of NDDs for professional athletes, more specifically professional rugby athletes. So now looking at the methodology. This was a respective cohort study accessing electronic records where it analyzed death record certifications, hospital admissions, and administered medications. They look specifically for using this book by Kenneth R. Bogle called The Scottish Rugby Game by Game, where 412 former professional male Scottish rugby players were identified in order from 1890 to present in order to be able to use their information and match them to current general population reports. Looking more specifically at the amount of general population reports, we used 1,236 reports. Using this, we use each side in order to match them by age, sex, and area socioeconomic status using a community health index number in order to really quantify the difference between somebody who's a professional athlete and someone who's a just in the general population, but they still have similarities within where they come from, their age, their sex, etc. So looking more specifically at the table, we can see that this is the cohort demographic information. There's a number of percent of SJMD that you can see that it's quantified between every single person. Then you're looking more at player position, which applies more to the international rugby players, where it lists every single part of the position, and then just looking at the age and year of birth for each population group. Now looking at the findings, over a median of 32 years follow-up study of using the Cox proportional hazard calculation, we can really see that there's actually no difference in age and mortality rate between the two groups, where 121 players out of 412, which is a 29.4% of rugby player mortality rate, compared to only 381 people out of 1,236, which is 30.8% of the general population mortality. So in reality, there's really no huge difference between the rate of mortality. And then looking more specifically at the age, you can see that 78.9 was the average age was a standard deviation of 10.2 years, being the rugby player's age of death, versus the 76.4 years old, with a standard deviation of 11.4 years for the general population's age of death. However, we can see that there was actually a lower risk of respiratory disease, but a higher risk of neurodegenerative diseases being the reason for death behind these rugby players. So looking more specifically at this page right here, this bit data table, respiratory disease was only found in 11 cases of death, which is only 2.7%. However, 43 people, which is 3.5% of the general population, was actually found to be experiencing respiratory disease towards the end of their life. But then looking more at the neurodegenerative disease, 11 people, which is 2.7% of the population that died in the rugby players, was actually much higher than the 18 people, which is only 1.5% of the population. So it's something to keep in mind that really like enforces that CTE and that contact sport and injury to death connection. And continuing on the findings, we can see that neurodegenerative diseases outcomes among former international rugby players compared to that of a matched population comparison group. You can see that there is a huge amount of these neurodegenerative diseases that were matched to a population group. So you can see how all of these rugby players were actually connected to other people who had some neurodegenerative disease. And really just noticing that there were higher numbers of rugby players having these NDDs compared to the population group, which was matching the same amount but in a much larger population, which just goes to show the frequency of these NDDs appearing in rugby players being much higher than the general population. So these are some of the conclusions that the article came up with. NDDs being the cause of death for professional rugby players is much higher than the general population. And this aligns with other studies done by the NFL and other sports organizations, which really reinforce this relationship. There's really no difference of NDD frequency by positions for rugby, which basically means that there's no specific position that should be looked more in focus or looked more for safety, when in reality, all positions are at risk of being exposed to NDDs. And then sport-specific influences on long-term health were actually something that was found. And looking specifically at soccer versus rugby, you can see that soccer really decreased the amount of cancer and cardiovascular disease being the cause of death, when rugby didn't really have an effect on that. So it's really interesting to see how different sports might have different influences on the health that somebody has over long-term periods, especially when it comes to different plays. In rugby, it's a lot more tackling compared to soccer, where you do more slide tackling on the floor. So it kind of like puts that into perspective, where you really need to look at what the person is doing in the sport in order to be able to determine how to analyze each NDD and each type of disease that might affect them in the long term. And then overall, just the reinforcement of NDDs and contact sport risks, and really just knowing that there's a really strong connection between lifelong health concerns and these NDD and contact sports in general. This is like a pyramid of connections that always influence the way people live. So these are some of the limitations that the article had. It was missing data and had unmatched players. So 37% of the found rugby players' records could not actually be matched to any of the general population's records due to many different missing demographic and general information that made it difficult to be able to match them. There was limited general implications. This was a very specific study that looked specifically at Scottish professional rugby players, but it can be somewhat stretched in order to be able to apply to other people, but it's very difficult to try and make that connection. And there's also potentially underreporting of cases. It was utilizing a very specific criteria in an electronic database that can cause this severity NDD to be underreported from actual real life occurrences. The electronic database may not include all people that might fall under this criteria. Um, and it might just cause people to think that the severity of what this and the NDDs for contact sports might actually to think that it's much less than what it actually really is. So it's something that to keep in mind. And these are my references. I just used the article that was assigned. And thank you.
Thank you so much, Kevin, for that excellent presentation. Are there any questions, or Dr. Lopez, do you have anything to add?
No questions. If you don't mind, Kevin, please go to I think it's the third or last slide. In your presentation, you said there was a increased right there. Now, in the general population, I think maybe you wanted to clearly emphasize that this was in the general population of Scotland, right? Not,
Actually, the
sorry, go
sorry,
ahead. Or did they
the
say the general population overall, maybe the United Kingdom? I wanted to make sure we clarified what that was.
yeah. So when it comes to general population, it was where the study was originated in. So I'm pretty sure this is the United States, which is also another cause of concern for limitations because they look specifically at Scottish rugby players, which is something that, different lifestyles and different things might collide in that sense.
Yeah, and then I also want to point out the third bullet point there that, you know, sports specific influences on long term health. Obviously, soccer does quite a bit of, long distance running. They run quite a bit, right? Not as compared to rugby, they run, tackle 15s. I'm assuming that this is not rugby sevens. I want to make sure this is clearly understood that the implications of rugby sevens is probably more in line with soccer. And if they took this data historically, rugby 15s was played at a slower pace than it is now. Rugby 15s is at a very different pace, than it did historically. There's more running and at a faster pace. These athletes are stronger than historically in that of athletes that played the sport. Also, it was very different early on. Did they say that the time frame of when they took these patients or
Yeah.
these cohort, the
Yeah,
years?
so if I go back here, you can see
This,
here that these were taken from the 1890s to present, so it could be any of the records between that time period.
yeah, there was a lot. You got to remember, right? 95 was when rugby really became professional 15s as compared to rugby sevens in 2016. So rugby, um, became professional, and therefore, there was a change in mindset. But they collected this data all the way back in 1890. Um, you know, there was quite a bit of debauchery during that time. A lot, there was a lot going on. So I do understand that this study, did a great job in trying to search out this data, figured out or provided a, a a model of how to conduct a study of this nature, within a cohort. But there are many, many limitations, I would say, looking at the sport, the professionalism of the sport, you know, what occurred during the early, 1900s in the sport. Also, the population of what they compared it to. Am I correct on this? They compared it to overall population or global numbers,
Yes.
and that's a big limitation. Obviously, they're looking at a small cohort, you can't generalize the implications overall to the larger landscape. I just want you to all understand that. Again, thank you, Kevin.
Thank you.
Thank you so much again, Kevin, for that excellent presentation. Now, our second intern is Chris Francini. Chris, could you please introduce yourself and share your screen with us?
Hi, everyone. I'm Chris. I'm a rising senior at Northwestern University studying neuroscience and Spanish and on the pre-med track. So today I'm going to be talking about intra-articular pure platelet-rich plasma versus leukocyte platelet-rich plasma for knee cartilage lesions from a paper written by Zhao and others in the Orthopedic Surgery Journal. To start, I wanted to talk a little bit about background. So looking at knee cartilage lesions, we can start with the image on the right on the femoral condyles, where we often see knee cartilage lesions that, when very serious, will often be repaired through osteochondral allografts or autografts, where the surgeon will take out the piece and replace it with an autograft, which is some of your own cartilage harvested and put back in, versus an allograft, which is a donor cartilage. In this case, we're looking at how PRP and other methods can help reduce this bone-on-bone scratching crepitus that really leads to this arthritis in these osteochondral arthritic areas. So talking about the reason why we have these lesions is that cartilage, unfortunately, does not have great vascularity, meaning not a lot of blood gets to this area, not a lot of nutrients, and not a lot of white blood cells to fight this crepitus that is occurring and this damage that really leads to a lot of pain and inflammation in the knee area. So often these, to start, are treated with cortisone and hyaluronic acid. Hyaluronic acid acts to lubricate the area and to ensure that there's a little more rubbing and fluidity in your knee movement. Um, on the other hand, a new development, platelet-rich plasma, is taking our own blood, centrifuging it, and isolating the growth factors and leukocytes and all these great nutrients that we can inject back into the source to concentrate them and hopefully help heal. And it has proven to slow arthritis in areas where we may have lesions, especially these knee cartilage areas. So a benefit of it is that it is simple and minimally invasive. So the central question is whether looking at this study, looking at this paper, is whether pure platelet-rich plasma is better, where leukocytes are ignored and not taken in the injection, or leukocyte platelet-rich plasma, where we take that buffy layer where the leukocytes are present and inject it to see if those white blood cells do have an effect in managing this arthritis and arthritic areas, these lesion areas. So this study was a double-blind, randomized control trial with a large sample and a year follow-up. So looking at the methods, there were taken 60 patients who had less or than or equal to grade 3 Kellgren-Lawrence cartilage lesions, as seen in the image on the right. So we did grade 4 lesions were not taken into account. So, and then they were randomized 1-to-1, 30 people were given the pure platelet-rich plasma, while 30 other people were given the leukocyte-rich platelet-rich plasma. And these people were between ages 18 to 75 and had knee pain for longer than 3 months. And then the injections were given for three injections over a total of 14 days, and they were studied. So, in order to prepare the platelet-rich plasma and leukocyte platelet-rich plasma, they're very similar ways to prepare and ways to isolate the growth factors and white blood cells. So you centrifuge it, spin it down. That way, all the layers are separated, where we can get the platelet-rich plasma at the bottom, in that bottom layer where it's filled with those growth factors, where a little bit above there's a buffy coat where the white blood cells separate themselves. So the leukocyte platelet-rich plasma was taken up using this buffy coat, and the leukocytes were kept where the pure platelet-rich plasma was only taken that bottom layer filled with the growth factors. So for this trial flow and participants, 95 patients were originally assessed for eligibility, and 35 did not meet the criteria, and 30 were randomized into each group with pure platelet-rich plasma or leukocyte platelet-rich plasma, and a few, unfortunately, were lost to follow-up. So in order to study, in the next slide, I'm going to go into a little bit of the data, but to see the studies and to see how pain intensity was assessed, first, the VAS, the visual analog scale, was used, where physicians are seeing how and managing how these patients are seeing pain in their knees after these injections. Whereas on the other side, the WOMAC was used to have self-administered results, a questionnaire that asked the patients personally how they were feeling and how they interpreted their pain and stiffness. So as a result, both groups improved at the beginning. So we can see that in the first 6 weeks, there was a WOMAC score that dropped from around 38 to about 26 for the PPRP and the LPRP, which was very interesting to show that this early onset relief was pretty pronounced. And unfortunately, it flattened out. And then at 12 months, it got a little worse, which can be due to the fact that these patients were probably getting back into daily activity and trying to push themselves a little bit harder. Another key finding is that pure PRP had an early edge. Looking at the VAS motion test, where the physicians were testing how the patients were looking in their motion and their ability to have different degrees of flexion and extension in their knee, we can see that the pure PRP had much more motion than the leukocyte PRP, with the p-value much lower than 0.01, which means this was not attributed to random cause. Although they evened out at the end and the gap closed into 12 weeks and 6 months and 12 months, we can also see, excuse me, that the WOMAC pain's significance in this chart down here showed similar findings where the patients were actually reporting themselves that the pure PRP showed better early onset in the early rehabilitation phase, which is to be taken into note. So another thing we have to look at when looking at PRP, given it's such a new technology, is the safety and the adverse events that go into it. So throughout the study, the experimenters took a large focus on looking into complications and saw 15 total complications. And focusing on this graph here on the right, we saw that with leukocyte platelet-rich plasma, we saw many more complications, which can be due to the fact that leukocytes are inflammatory cytokines. So when leukocytes are when in use, these white blood cells go to an area and they inflame the area, and there's a big process that goes on. But while that does aid in infection prevention, inflaming an area that it has more inflammation already due to the bone-on-bone scratching that's happening, the crepitus, and the lesions that have occurred is not so ideal when looking into how a platelet-rich plasma can help a patient like that. The experimenters found that pure platelet-rich plasma did not have as many adverse effects. So I kind of thought this MRI was really interesting and wanted to take it into account, looking at the signals from A to B and C to D with the pure PRP case and the leukocyte-rich PRP case, showing that this technology is working. We see more crepitus down here in this region, and here we can see there's a much fainter signal in that knee area on the femoral condyle. So it's interesting to see, in the real world that patients are experiencing relief while it may not be, and the data showed that long term it's not super, super effective, but in the short term, it's giving early rehabilitation data that has been promising. And so, unfortunately, some limitations with this study is that it's small, and there was only a 1-year follow-up. So the experimenters didn't really get if these injections are working for longer than a year, and they saw, or maybe becoming even more averse after a year. And unfortunately, there was no control. In conclusion, I think that seeing this data and having read this paper, both pure platelet-rich plasma and leukocyte platelet-rich plasma have shown to reduce pain and reduce stiffness in the early times after the injection. And there's not so much data yet as to more long-term, given it's a new technology. And yeah, long-term efficacy is similar for both and unfortunately does weaken after that time. Here is the paper that I referenced it off of, and thank you very much for listening to my presentation. Any questions from anybody or comments?
Thank you very much, Chris. That was an excellent presentation. As you said, any questions, or Dr. Lopez, do you have anything to add?
left or no questions, anyone? All right. No, great job there, Chris, and good choice on the article. I think what happens is that if you go back to your conclusions there, sir, go back one slide, please. You know, in any study, there are limitations, right? You can try your best. There's not an exact science, it's an art. When you come up with such important a clinical trial like this that has impact, obviously they only had a small cohort, but the small sample size that they used. But the unique thing about it is the findings that to try to even come up with this and even to understand it. The amount of internal, institutional review board hurdles to conduct a study of this nature, let alone to do an impact where you're injecting into a human, it probably was a lot to even get this done. So kudos to the authors for trying to do this, but like I said, there's always a limitation. I think they said that both reduced pain and improve function. But the PRP gives a better early efficacy and fewer adverse effects. Like I said, I think you said you have to wait longer than a year to really find out. Also, did they break up this population? Were they young? Were they active? Were they older patients? How did they obtain the injury? Was it trauma? Was it overuse? These are a lot of factors that need, they could have attempted to categorize them, but again, it's always very challenging to try to get, if you're trying to get the outcomes out, you can't get caught in the weeds. But the big question is, the cohort that they chose, you need to ask those questions. What were their limitations? Were these all, healthy, active age folk that, maybe some of them are still in sports? Did they limit them on sport? They didn't say if they limited them on, extra activities, and again, you can't stop a young, healthy, person from being involved in other things or in sport. So it's still challenging, you don't know what the outcomes were. But Chris, I don't know if you have anything to comment on that.
Yeah, unfortunately, they used a very large range of samples. I think it was like 18 to 75 years old. So there's not a ton to say, unfortunately. I think if you did this with athletes 18 to 25, you could probably get a little more concise review of it and see what's happening. But using older people in it can probably mess with that data, and it was a big sample size.
Yeah. Big age range in that. I did see that though. All right. Good job there. Thank you though.
Okay, then that will conclude week 4 of the RISE Institute and Rugby Research and Injury Prevention Group Journal Club. Thank you all for attending.